This video demonstrates robotic TAPP repair for a large direct inguinal hernia. After going inside, you can see around 4.5 centimeter defect. This 70-year-old gentleman presented with a long-standing reducible large right-sided inguinoscrotal hernia, and the momentum and small bowel were content. So under anesthesia, when you position the patient, the contents were reduced, and since it is medial to the defect is medial to the inferior epigastric vessels, so it's a direct inguinal hernia. So you can see how big the hernial defect is. So I've started raising the flap 4 to 5 centimeter proximal to the upper border of the defect and gradually going down. So laterally we'll be creating space of Bogros, and medially we'll be creating space of Regius. But safeguarding the inferior epigastric vessel at the top, you can see the bare surface of the right undersurface of the right rectus abdominis, and also the inferior epigastric vessel just lateral to the rectus abdominis muscle. And by definition and anatomical aspect, we know that direct hernia arises from the Hasselback's triangle that is bounded by rectus abdominis, inferior epigastric, and the pubic bone. So this is a typical of direct hernia. So you can see laterally I am just raising the flap and trying to create more space in the space of Bogros. So gradually releasing all the loose areolar tissue and staying in the loose areolar tissue plane, and leaving the fat onto the abdominal wall is actually will give you a bloodless plane of dissection. So you can see, and now I have initially it was 30-degree up camera. Now once I have dissected from roof down towards the pelvis, I've changed the camera position to 30-degree down, and gradually very gently I am just trying to create a space between the pre-peritoneal fat and the dulux fat. So laterally I am trying to create the space of Bogros further down, and now you can see the inferior epigastric vessel, and the once I pull the peritoneum, I can see the pseudosac coming with it. Is a thick pseudosac, a long-standing hernia. So I'm trying to gradually release all the adhesions with the peritoneum and the pseudosac and trying to reduce it. So sometimes there are small blood vessels which can bleed in this process, and if it is not properly addressed, then there is chance of post-operative hematoma formation in the scrotum. So that should be taken care of while releasing the pseudosac. There should not be any bleeding which is not properly coagulated. So carefully it should be dissected. And medially sometimes the bladder comes as content in large direct hernia. So that is also a point of concern when there is large direct hernia. While releasing the pseudosac and bringing down the peritoneum inside, you should take care that bladder should not be injured, and whether the bladder is content or not, that should be taken care. So now you can see I have done most of the release of the pseudosac from the preperitoneal fat, and very gently and cautiously with the tip of the scissor using monopolar energy I'm releasing it. Now I'm going on to the medial to the defect margin towards the space of Regius, and once we release this we can see the Cooper's ligament. So glistening Cooper's ligament is a lighthouse sign, and coming down towards the cord structure. So pulling the peritoneum and seeing what are the structures which are holding, try to identify the intervening tissue between the cord structures and the peritoneum, and releasing it with the tip of the scissor. So laterally there will be gonadal vessels, medially there will be vas difference, and we should go at least 5 centimeter from the defect margin below. So there will be adequate space, and this step is known as paratalization of the cord structure. So that once you release all the tissue, the peritoneum and the cord structures will be completely separate, and that should be at least 5 to 6 centimeter from the point from the point of internal ring. So here you can see further dissection medially. I'm trying to go down. So there are certain landmarks that should be seen before saying that the dissection is complete. So number one is where that vas is turning medially, we should try to go up till that point. Now the next thing is medially the dissection should be at least 2 centimeter below the Cooper's ligament, and laterally there should be enough space, at least 5 to 6 centimeter space, so that the lateral margin of the mesh should lie flat and it can be nicely accommodated. So you can see a layer of fat is lying over the nerves of in the triangle of pain. So that is the Dulux fat. Now the medially we should cross the midline. So I'm just releasing the adhesions, releasing the adhesions in the peritoneal plane, so that I can cross on to the opposite side. So the medial layer of fat is divided, and now we can see the symphysis pubis in the midline. And once we cross the midline, the mesh should cross the midline once it is placed. For that, the dissection area should be adequate. So now you can see, so dissection area is dissection is complete. So all around 12 by 15 centimeter mesh should be placed, so that the adequate space is created. Now as there is a large direct defect and there is a large sac, so I decided to plicate the sac with the Cooper's ligament. The advantage is that that will prevent postoperative seroma formation. And number two is patient will not feel any bulge in the postoperative period, that is known as pseudo hernia formation. So that there is a concerning thing for the patient. So I'm asking my assistant to put pressure on the sac from outside, the Pseudosac, and then plicating the Pseudosac with the Cooper's ligament nicely, so that once we pull the suture I'm using is 3-0 absorbable V-lock. It will get fixed with the Cooper's ligament, and there will be no bulge externally. So it should lie completely fat from the outside. So it is done, and now the 12 by 15 centimeter mesh is placed inside after fashioning it properly. And if the dissection area of dissection is adequate, you can see after placing the mesh inside and unfolding it, it will automatically lie in this preperitoneal plane, that is the myopectoneal orifice on the right side. So before that, we have achieved the critical view of myopectoneal orifice, which is prerequisite for before placing the mesh in any groin hernia repair. And if the mesh is sitting nicely, there is no need to fix the mesh. And now I am closing the peritoneal flap. So here using the 3-0 absorbable V-lock suture with backhand suturing, which is the advantage of doing robotic instruments. The versatility of robotic instruments, the wristed instruments, will actually help in suturing, giving backhand stitches. And these are the dolphin stitches that I am putting, so that once we pull the suture gets buried. So this patient had an uneventful recovery and discharge within 24 hours from the hospital, and doing well in the post-operative period. There was no post-operative pain, and the patient was mobilized within 4 hours. The patient was pretty comfortable. There was no seroma in the post-operative period on follow-up period. Thank you for watching this video, and keep watching for more videos.